There's a conversation that happens at some point in most mesothelioma patients' journeys. It's a talk that no one looks forward to, but it's one of the most important discussions a patient and their family can have. It's the conversation about treatment goals, about what the treatment's actually for, about what we're trying to achieve, and whether that goal has shifted. It's the conversation that moves from the language of fighting and curing and shrinking tumors to the language of comfort, quality time, and what matters most to the patient. Today, I want to talk about that transition from a treatment focus aimed at controlling or slowing the disease to a care focus centered on quality of life in a way that's honest, compassionate, and genuinely useful to the people navigating it. I'm Terri Oppenheimer. I've been writing about mesothelioma and asbestos for the website mesothelioma.net for over a decade. And I want to acknowledge right from the start that this is not an easy topic, but it's an important one. And I believe that people facing mesothelioma, patients and their loved ones, deserve clear, honest information about what palliative care is, when and why the focus of treatment shifts, and how to navigate that transition in a way that honors what matters most to the person at the center of it all. Let me start with something that surprises many patients. Palliative care is not the same as giving up, and it's not something that begins only when curative treatment ends. This is one of the most persistent and most harmful misconceptions about mesothelioma care, and I want to address it directly. Palliative care is a specialized approach to medical care that focuses on providing relief from pain, symptoms, and the stress of serious illness. Its goal is to improve the quality of life of both the patient and their family. According to the World Health Organization, palliative care is appropriate for patients with serious illness at any stage, and it can and should be provided alongside active cancer treatment from the time of diagnosis. It's not a signal that the disease is winning. It's a recognition that the person with the disease deserves to be as comfortable, functional, and supported as possible at every stage of their journey. Evidence supports this. A landmark 2010 study found that lung cancer patients who received early palliative care alongside their standard oncology treatment had better quality of life, better mood, and fewer depressive symptoms than those who received standard oncology care alone. Amazingly and counterintuitively, they also lived longer. There was a 2.7-month improvement in median survival in the early palliative care group, despite the fact that they were actually receiving less aggressive treatment at the end of life. This is proven true in multiple studies across cancer types. A systematic review and meta-analysis published in Cancers in 2023 found that early integration of palliative care was associated with significant improvements in quality of life and symptom burden across multiple studies of advanced cancer patients. The research is clear. Rather than being a retreat from fighting disease, engaging palliative care early is a smarter, more complete way of supporting a person who has any serious illness. That absolutely includes mesothelioma. There was a trial called Respect Meso that specifically tested this in patients with mesothelioma, and it compared early referral to specialist palliative care versus standard care in a multi-center randomized trial across 20 sites in the United Kingdom and Australia. While it didn't find a statistically significant improvement in the 12-week primary quality of life measure, it found significantly higher carer satisfaction with end-of-life care in the palliative care group. This suggests that the benefits may be particularly pronounced for the family members and caregivers who are by the patient's side throughout their journey. Mesothelioma has a high symptom burden from the beginning. Chest pain, fatigue, and anxiety are common at diagnosis and throughout treatment. The early involvement of a palliative care team that includes physicians, nurses, social workers, chaplains, and others means these symptoms get consistent attention alongside oncology treatment. Now, I'm going to take a break here to ask you a quick favor. If you find these videos helpful, please hit the like and subscribe buttons below. It makes it easier for other people who need this information to find us. Also, if you have questions or there's a topic you'd like to see addressed in a future video, send me a note in the comments section. And make sure you watch until the end, because I'm going to give you valuable information on where to find resources that will make a real difference for you. Now, I want to talk about the transition itself, the point at which the primary goal of care shifts from controlling the disease to focusing entirely on quality of life and comfort. This transition happens at a different time for every patient. For some, it comes after multiple lines of treatment have been tried and the disease has continued to progress. For others, it comes when the side effects of continued treatment feel more burdensome than the potential benefit. For others still, it comes as a deeply personal decision that's less about what the oncologist recommends and more about what the patient values and what kind of time they want to have. What prompts this conversation? It might be imaging that shows significant disease progression despite treatment. It might be a functional decline. Patient is weaker, less able to tolerate treatment, spending more time in bed. It might be the development of complications that suggest the disease is advancing more quickly. Or it might simply be the patient's own feeling that they want to shift their energy toward living well rather than treatment schedules and side effects. There is no single trigger, and there's no right or wrong answer about when this shift is appropriate. It's a decision that belongs to the patient, ideally made with their family and their medical team, and it can be revisited and changed at any point. What does a palliative-focused approach to mesothelioma care look like in practice? It looks like a care team whose primary goal is making sure the patient is as comfortable and functional as possible. It means aggressive attention to pain control. Mesothelioma can cause significant chest wall pain as it progresses, and managing that pain well is a central priority. One of the most distressing symptoms of advancing pleural mesothelioma is breathlessness, and a palliative-focused approach means treating that with medications including low-dose opioids, as well as using fans, positioning, and other non-pharmacological approaches. It means addressing the anxiety that often accompanies breathing difficulty and the serious illness itself with medication, counseling, and the presence of a team that knows the patient well. It means support for the family members who are working so hard to care for someone they love. Hospice is a specialized care program that provides palliative-focused support when the focus has fully shifted to comfort and the patient has a prognosis of 6 months or less, assuming the disease follows its expected course. Under Medicare in the United States, hospice benefits cover a full interdisciplinary team: physicians, nurses, aides, social workers, chaplains, and counselors, as well as medications related to the terminal diagnosis, and for many, care in the home. Hospice care can also be provided in inpatient hospice facilities, nursing facilities, or hospitals. Choosing hospice also isn't giving up. It's choosing a different form of very active care that's focused entirely on the person rather than on the disease. One of the most important things I can say about this topic is something research consistently shows. Patients who engage palliative care and hospice at appropriate times, rather than continuing aggressive treatment until the very end, often experience better quality of life. They spend more time at home and less time in the hospital. And in some studies, they live as long or longer than those who pursue aggressive treatment until death. Patients and families should never feel that choosing comfort-focused care is somehow a lesser choice. It's frequently the more courageous and more clear-eyed one. If you're navigating this transition or helping someone you love as they navigate it, I'd encourage you to ask for a palliative care consultation if one isn't already in place. Ask your oncology team directly what treatment is now realistically likely to accomplish and what the balance of burden and benefit looks like at this stage of the disease. Have the conversation with family about what matters most, not just about treatment, but about how to spend the time available in a way that reflects who the patient is and what they value. And know that whatever direction you choose, you and your loved one are not alone. To review, palliative care is not the same as giving up. It's specialized care focused on quality of life, and it can and should begin early in the mesothelioma journey alongside active treatment. The transition from disease focus to comfort focus is deeply personal and should be guided by the patient's values and informed by honest conversations with the medical team. Hospice provides comprehensive support when the focus has shifted entirely to comfort. And research consistently shows that patients and families who engage palliative care early and hospice at the right time experience better quality of life throughout the journey. You can visit mesothelioma.net for more information and resources on palliative care and hospice, and support for mesothelioma patients and their families. Or call us at 1-800-692-8608 or use the live chat feature on the website to speak to someone right away. As for me, remember to post questions below, and I'll see you next time.